Okay, well, let's begin. Margaret, I want to thank everyone for joining us to hear Margaret Roach's presentation about her year as Wofford's Presidential International Scholar. For more than 30 years, the college's presidents have selected one student to serve as a Presidential International Scholar. This student is someone who has demonstrated exceptional potential to benefit humankind, a passion for service learning, and globally minded intellectual curiosity. Our scholars spend their year conducting research around the globe. Margaret spent the year researching the integration of traditional medicine with the biomedical approach to treating mental health in India. Unfortunately, she had a unique experience. The COVID-19 pandemic prevented Margaret from traveling to India, but she still found ways to gather information, conduct interviews, and gain personal insight on ancient Indian therapies. So she innovated and was creative in confronting adversity. And in part, that's what the Presidential International Scholar does. Margaret is a graduating senior from Winston-Salem, North Carolina, majoring in psychology with a concentration in medicine and the liberal arts. She's attending UNC Chapel Hill, earning a master's in public health focused on health equity, one of the most significant issues of our time. I ask you to please submit questions in the chat box. The college's Office of Marketing and Communications will be on the lookout for questions and share them with Margaret. Of course, if you'd like to ask your question on camera, just indicate that and you'll be allowed to turn on your camera and be unmuted. And now, Margaret, we're ready to hear from you. Congratulations.
Thank you so much, President Samhat. I so appreciate that introduction. I am going to start to share my screen. And all right. So good afternoon, everyone. Thank you so much for attending my presentation. Thank you to the marketing team and to IT for all the work that they put into planning and hosting this. As President Samhat mentioned, the title of my research is the integration of traditional healing and biomedicine to treat common mental disorders in India. Just as an overview for this presentation, I will be presenting on my topic for about 20 minutes, after which, as President Samhat mentioned, I will be taking questions. Before I go any further, I do want to acknowledge the context in which this research occurred. Because of the COVID-19 pandemic, I was unable to travel to India this year. And India is currently experiencing a huge second coronavirus wave that is accelerating beyond anywhere else in the world. So if you get nothing else from this presentation, I do hope that you take the time to do some research and learn about what is happening in India and potentially find a way that you can help. Before I get into my question, I do want to provide some definitions and background and context into my research question. Common mental disorders are what I decided to focus on as a narrower grouping of mental disorders rather than the wide range that exists. So common mental disorders include mood, anxiety, post-traumatic stress, and substance use disorders. It's estimated that about 10% of India's entire population lives with a common mental disorder. This is coupled with a shortage of mental health professionals in India. There are only 4,000 psychiatrists in the country, which equates to 0.3 psychiatrists per 100,000 population. To put this in comparison, the United States has around 247 psychiatrists per 100,000 population. What results from this deficit of human resources is known as the treatment gap, which is defined as the proportion of people with a mental disorder who do not seek care or who do not have access to care. Worldwide, the treatment gap for mental disorders averages around 50%. So this means around 50% of people who have a mental disorder do not have treatment. In India, the treatment gap is larger than average, which is measured to be upwards of 80 to 90%, making it a significant public health crisis. The models of medicine that are used in high income countries, or you might hear me refer to that as the global north, follow a biomedical model. The biomedical model places emphasis and prioritizes on human resources. So to treat mental illness, you need psychiatrists, you need nurses. And this biomedical approach was exported to the global south or low to middle income countries when they were colonized. But this approach might not be appropriate for all countries in the global south because of the fact that the global south and India specifically lack medical personnel, psychiatrists, physicians, et cetera. So it is not the best way of treating population health. I came into this research project hoping to propose the integration of traditional medicine and biomedicine to close the treatment gap of common mental disorders. But due to travel restrictions and after doing more research, I really felt that I was narrowing in on what I was focusing on to the question that you see on the slide. How do you address mental illness as a public health crisis when you have a shortage of mental health professionals? Though I will still address my original research question and describe what I learned about that too, with the traditional and the biomedical approaches. Before coronavirus, my plan was to visit India and Thailand, originally during the fall semester. I tried during the spring semester too, and I even tried to go during interim. But obviously none of those worked out due to the pandemic. So I ended up doing background research during the fall of 2020 with the hopes that that would give me a foundation upon which to conduct research either abroad or from Wofford during the spring or interim. So that did lay a great foundation for me to then, over the past month, I've been doing independent research as my interim project, which involved a visit to Albuquerque, New Mexico, which I'll describe a little bit later. And I was able to interview experts on Zoom from across the globe in global and mental health. In my next few slides, I will be presenting the results from my literature review, my visit to the Ayurvedic Institute in New Mexico, and my results from my interviews. I'll pretty much just be going over themes that were consistent throughout these experiences. As I began my research, what I found is that most of the current work being done to close the treatment gap in India is to incorporate mental health into primary care. So what I learned is that primary care workers in India are mostly not trained how to detect, diagnose, and provide treatment for mental disorders. So this kind of became step one of my research and what's currently going on in India. Successful interventions that incorporate mental health into primary care have built off of existing public health structures in the country, utilizing resources that exist within communities, allowing them to be sustainable. However, there's still a problem because public health and primary care centers are not available to all populations in India, particularly rural or tribal populations might still be so far away from a primary healthcare center that they can't access it. So this alone does not adequately address the burden of mental illness. I already discussed that psychological treatments rely on mental health professionals for delivery. Thus, there must be efforts to increase the number of competent primary care workers in Indian settings so that more people can receive adequate treatment for common mental disorders. The answer to this question is known as task sharing, or you might hear me call it task shifting. This is a broader practice that's been used in global health, and it's now being applied to mental health care too. It refers to collaborating with non-specialist providers, such as lay individuals or community health workers, to deliver healthcare services that are traditionally relegated to doctors or people with professional degrees or certificates. Task sharing works by training these individuals to identify, diagnose, treat, or refer people with mental disorders. These individuals are typically overseen by researchers on a project or psychiatrists. Most research in task sharing for community mental health focuses on medication adherence, administering counseling sessions, conducting anti-stigma campaigns and educational campaigns, And most successful approaches have also relied a lot on technology. All of the psychiatrists that I interviewed were involved with one or more research studies using task sharing to incorporate mental health into primary care. Their work has shown benefits and promise on local district levels in India. So most of their studies are now working to systematically improve detection and treatment of mental illness in primary care on a larger scale. So they're studying it in larger Indian states with the hope of eventually national studies or national implementation. The barriers that I identified in the literature and in my interviews, there are many, but I tried to summarize 6 important ones here. So first is, like I already mentioned, that primary healthcare workers are often insufficiently trained at detecting and diagnosing and treating common mental disorders. This requires a restructuring of entire educational systems, meaning that doctors in their education should be learning, and hopefully eventually they get to a point where they're learning in medical school how to do these things, how to diagnose and treat mental illness. But you can't just do that on a whim. Obviously, you need funding to do that. So a lack of resources, such as funding for this type of training, even having medications available, is a barrier. Having or keeping up motivation with the non-specialist providers that I mentioned that conduct task sharing is pretty difficult. And I've seen a lot of different strategies to keep up motivation in different studies of these non-specialist providers. Stigma is another barrier, stigma among the general population and healthcare providers themselves. And a possible reason for the inability to scale up task sharing models may be that public health systems in India are overburdened with addressing other health needs. So there might be limited time and resources and energy to devote towards mental health. And this is especially true during the COVID-19 pandemic. I'm going to switch gears a little bit now into my original research question. So I want to talk a little bit about what traditional healing looks like in India and describe what that is. So despite traditional healing systems' pervasiveness in the global South particularly, scientists, medical doctors, and stakeholders might view traditional healing as a culturally appropriate but poor alternative to biomedical health systems. This is because under the scrutiny of so-called Western science, traditional healing does not adhere to the same measures of determining efficacy. So this is why global health policy has typically ignored the contributions that traditional healing has. There is a debate about how much of India's population actually uses traditional healing. But most of the literature agrees that there is some proportion of individuals, some you see on the slide, somewhere between 11 and 20% of the population utilizes traditional healing. Most people describe using it either as complementary to biomedicine, so using both systems side by side with one another, or in situations where biomedicine fails to alleviate their symptoms or treat their disorder. One point of agreement among experts in this field is that traditional health practitioners vastly outnumber the number of psychiatrists and mental health professionals, which creates the potential for traditional healers to occupy a space in the workforce that's left empty right now in the formal healthcare system. An example of a formalized system of traditional healing in India is Ayush. You see the definitions for Ayush on the slide. It was government recognized in 2014, but less than 1% of all Ayush consultations are for mental illness. However, that number is estimated to be a lot higher, given that many service users report physical symptoms rather than psychological symptoms, either because they don't realize what it is themselves or to avoid stigma. There are so many other forms of traditional healing that are not government recognized in India, but due to my inability to travel, I focused most of my research on Ayurveda, the first part of the Ayush acronym, as it was just most accessible for me to study in the United States. This is where I get to talk about the week that I went to New Mexico. So I went to the Ayurvedic Institute in Albuquerque, which was founded by a doctor from India, Dr. Vasant Lad, almost 40 years ago. Ayurveda translates to the science of life, and it is about feeding the body, mind, and soul. My week in Albuquerque illuminated to me how Ayurveda can support someone with mental illness. And I say support specifically because we know that some people with mental illness do need medications and psychotherapy, but Ayurveda can be something that can support, improve treatment on top of those things, on top of medical treatment. So Ayurveda has suggestions for a daily routine, essentially a toolkit for users that encompass what the West might call lifestyle medicine. This is diet, pranayama, which means breathing, meditation, yoga, and exercise. And there is a wave of new research in the global north about all these things I just mentioned, with evidence that shows that each of these are beneficial for mental health, especially for reducing anxiety. In this way, it is understandable how traditional healing might be complementary to biomedicine when treating mental illness. The Ayurvedic Institute embraces biomedicine and even has educators there that are trained both as medical doctors and in traditional Ayurvedic healing. The belief is that both systems of medicine have a purpose, and where one fails, another can pick right up. I interviewed a practitioner from the Ayurvedic Institute who said that in an ideal world, the Institute could be entirely integrated. I thought that this quote on the slide from Dr. Lad, the person who founded the Institute, there's a documentary about him called The Doctor from India, that speaks a lot to my next transition. So I'll read this quote now. Ayurveda is not a quick fix. Ayurveda takes time, but allopathy means biomedicine, is very important for emergencies. Acute heart attack, stroke paralysis, fracture, or accident. There's nothing like modern medicine. The whole world needs modern medicine. But once acute emergency is over, then how can I prevent chronic disease? In that sense, there is a need of a natural way of dealing with this. That's why Ayurveda and allopathy go together. This is called integrative medicine, and integrative medicine is the future of medicine. As Dr. Lad said in the quote, the inclusion of traditional medicine into conventional biomedicine is known as integrative medicine. Integrative medicine aims to achieve a synergistic healing effect greater than that obtained using either modality alone. Given the traditional healer's potential in closing the mental health treatment gap, integrating the work of healers and medical providers across a variety of settings has the potential to improve overall well-being of communities. However, the proposals for how to do this, how to implement this change in integrative treatment diverge. Most publications endorse task sharing with traditional healers. So that would be using traditional healers the same way that I mentioned earlier with non-specialist providers. They would learn how to identify and even potentially provide treatment for mental disorders and refer anyone that needs a higher level of care into the biomedical system. There are advantages of doing this that include cultural acceptability of visiting a traditional healer, the accessibility of traditional healers. It's perceived to be more cost effective and is a holistic approach to care, and less stigma may lead to a better utilization. But other experts advocate for more dialogue and communication between the two systems, and say that by task sharing with traditional healers, you're not really utilizing their specific skill set. In a truly integrated model, traditional healers and biomedical physicians could cooperate fully. For example, referring patients to each other instead of just in one direction, consulting on complex cases, or even providing treatments in both modalities. For example, a doctor or a traditional healer could provide a culturally relevant explanation for a mental illness, followed by a culturally appropriate ritual and a prescription for medication. There are also significant barriers to integrating traditional healing and biomedicine. There's not even a lot of work being done in India right now to do this because step one of integrating mental health into primary care has still been such a challenge. But the challenges and barriers that I identified to integrating traditional healing and biomedicine are: first, it would require stakeholders, governments, educational institutions, and practitioners to recognize the benefits of traditional healing and the benefits of integrating. In my interviews, psychiatrists in India expressed that medical doctors there look down upon traditional healing. This poses a challenge, and any attempts to integrate would require an approach that engenders mutual respect and understanding between providers. As I discussed earlier, task sharing approaches might prioritize Western biomedicine, focus on traditional healers referring to patients rather than learning about traditional healers' own intervention process, advantages of their methods. This leads to the danger of biomedical professionals wanting to make traditional healers more like themselves, and while this might expand the reach of psychiatric services, it does little to capitalize on the healer's unique skills. In order to integrate, practitioners of biomedicine and traditional medicine will have to cope with the fundamental conflict of philosophies between Western views founded in empiricism and the traditional worldview based on faith, religion, or culture. A strong stance was taken in the literature and in my interviews by biomedical professionals against any traditional practices that are harmful or that intentionally cause pain. Some of these practices are considered human rights violations and must be addressed before integration is possible. Of the psychiatrists and researchers in India that I interviewed, most said that they would be willing to work with traditional healers, but believe the barrier of engendering mutual respect would be the most difficult to overcome. Although traditional healers are not currently a part of the formal health system, they are a major part of the informal health system, making it possible, despite the barriers, to include them in mental health, community mental health interventions. Treating mental disorders using task sharing approaches with non-specialists has so far been successful on local levels in India, and the next steps are to scale up, but funding remains the biggest challenge for doing so. A gap in the literature still exists on the integration of traditional healing and biomedicine. Therefore, future studies may want to consider this approach and investigate the efficacy of doing so. Mental disorders are not caused only by biology. Therefore, the treatments and solutions for mental illness must not be limited to only biomedical solutions. Closing the treatment gap should also include increasing access to psychiatric services, medication, but to be successful, it must also include methods to close the psychosocial care gap, addressing poverty, disability, unemployment, tackling things like addiction and domestic violence. And it is through this lens that it is possible to see that the solutions must be holistic. My study was limited by an inability to travel to India. Experts were also recruited by convenience sampling for interviews, and my experience with Ayurveda, despite being founded and exported out of India, is still based in a North American context. I want to say thank you all so much for coming to watch. Thank you again to OMC and IT for planning this. And a special thank you to President Sam Hatt, Dean Lancaster, and Dr. Lefebvre for being so supportive of me throughout this past year as we got through the whole year without being able to travel.
That's great, Margaret. Thank you so much. We have some questions and we'll get to them, but I get to ask the first question. So I appreciate, first of all, I appreciate how you adapted to very challenging circumstances and enjoyed the the process of working with you and Dean Lancaster to find solutions, given that we weren't able to travel to India. I guess two questions strike me. One is the equity issue, and that is it income driven in India? That is, I wonder if it's possible to unpack access to traditional health approaches according to income. And so it does fill a gap as a result of the lack of access for large numbers of lower middle and lower classes. So that's question number one.
Okay.
And then now question number two is a little different, and I won't say anything more after this, and that is, I wonder how, at least in the industrialized world, how insurance systems inhibit the adaptation of traditional approaches. And it occurred to me along the way, do areas of the country, or say Native American systems, to the degree that they may not have access to, and they don't generally have access to good biomedical approaches to health, do you find, and this is not India, of course, but do you find more robust use of traditional approaches, or do you think you would? So how does the insurance system and the structures of our insurance system inhibit this alternatives?
Yes, thank you for those questions. The first one about equity and access that different classes in India have. While I didn't focus on this specifically, I did come across research on who was using traditional healers, and the idea or the evidence that exists currently is that it's mostly people of low to mid income classes that use traditional healing versus higher class individuals. But there is only the perceived notion that traditional healing is more economically viable than biomedicine, so that it's cheaper. But I don't know that in practice that has actually been shown as evidence. So it's perceived to the users to be cheaper. Whether it actually is, that evidence I think is still up in the air. As for your second question, this was definitely outside the scope of my research, but I do know that at the Ayurvedic Institute where I was, they at least have to be very careful about how they can practice traditional healing in the United States without getting in trouble with, I don't know who they would get in trouble with, but like they can't use words like prescribe, obviously. They would never tell someone to go off of their medications. So they use more words like, we recommend this treatment for you, and they're limited as a place that does traditional healing. How much people who are trying to access traditional healing in our formal healthcare system are limited by insurance, I don't know the words how to quantify, but I agree with you that I think you're on the right path with that question.
Well, very good. Well, that makes me feel good. Being on the right path. We do have a question from Emmaggins. I think Dudley will bring Emma on.
Okay, I'm here now. I think I got cut out and then back in, so I'm assuming it's my turn. So hi Maggie, I loved your presentation, super interesting. I wish that you could have gotten to go to India and actually do that, obviously, but I have two questions. I was wondering, next year when you go to UNC, if you're going to be able to continue some of this research, or like in an international context, or maybe even have like the chance to go abroad again, or for the first time. But and then the second question, I wondered, your week at the Ayurvedic Institute, did you get to actually kind of experience some of those natural healing like styles that they do. If you could just like touch on that a little bit, but thanks.
Yeah, thank you, Emma. It's good to see you. She's calling in from France, everyone, by the way. So this is my cool abroad friend. Um, yes, I think there is a chance at UNC that I could continue this research. It'll all depend. I would want to. It all kind of depends on which faculty research I'm able to join, what their current research projects are. But I did find faculty within the public health school there that have research on mental health in India specifically. So I am hopeful that eventually I can work with those faculty, and then maybe that would provide an opportunity for me to go to India, whether it's continuing the research I'm on or something new that I find at UNC. And then at the Ayurvedic Institute, I did participate in treatments there. So basically, every day you have a consultation with a colleague of Dr. Laud's, and then you go through something called Abhyanga, which is a 2-person synchronized massage. The whole idea is like it's like a cleansing process. So everything that you're doing has a goal of cleansing. So Abhyanga, a steam treatment. And then my favorite part was something called Shirodhara. It's where they put oil over your head and it runs consistently for like 20 to 30 minutes. And when I heard about it, I think my own bias growing up in biomedicine was like, I don't know what that will do. Like, am I just going to be sitting there with my mind racing for 20 minutes? What's the point? Turns out it's the best meditation experience I've ever had. I got to do it every day for 5 days. It was unlike anything I've ever experienced. It wasn't like I was asleep, but I just meditated really well. So it's all it's a very physical process that you go through. There's other things too. It's a very physical process you go through, but it does bring a level of enlightenment. You get to check out a life for a week and go through this stuff. So there's a level of like self-reflection that you're able to do that you probably wouldn't be able to do in day-to-day life if you're doing that intensive a sort of treatment.
Yeah, that's really cool. And I'm sure it gives you a good perspective too, like learning about this and then experiencing it. I'm sure that's great. So thank you.
Thanks, Emma.
Well, we have another question from Professor Catherine Steinmetz and another one after her.
Hi. So I don't know how to turn my screen on, but I'll just do audio. So thanks so much for sharing your research with us. This question seems so vast, and you did a really great job outlining all the limitations. So I was kind of, oh, there we go. Okay, now I got video. Cool. So I was curious, if you were going to run a nonprofit, let's say, and you had a chunk of money to start chipping away at this issue, where would you start?
Oh gosh, that's a great question, Dr. Steinmetz. I think I would have to almost cop out this answer and say I would defer to the people that are on the ground in India, because they know so much better than I do what they're doing. And I wouldn't want to, with my funding or whatever, get in the way of the work that they're already doing. So I'd probably try to allocate those funds to the research projects going on right now that are trying to incorporate mental health into primary care first, and scale that up so that within the government system in India, there is healthcare for mental health. Before I probably tried to figure out anything to do with the traditional and biomedical approach, just because that seems further away and more difficult to accomplish right now and would take a lot of people on the ground working with traditional healers to do so.
That makes a lot of sense, kind of integrating the two worlds that are already there.
Yes. Thank you.
Well, we have Professor Trina Jones lined up, but I see Professor Bopp is on the screen. So, Kara, do you want to ask a question? And then Trina? Okay, we have more. Okay, Trina. Professor Jones, it's all yours.
Thank you. Margaret, that was so interesting. And I'm really impressed with the way you were still able to get something going, not able to travel and all that. So I'm really interested in the use of language and categories, the way we think about traditional medicine and natural medicine. And as you walked through your presentation, I was thinking about the fact that so many of the traditional systems like Ayurveda and yoga have their roots in religious systems and what we would think of now as Hinduism and Buddhism. Excuse me. And I was thinking about some of the bias or some of the problems with acceptance and that kind of thing. And I was wondering if you ran into that any in your research, the idea of it seems like the ideas of these systems of Ayurveda and yoga have become medicalized and talked about now in terms of healing and in terms of medicine now and of therapy. But a lot of the traditional healers in the past would have been called something along the lines of priests. But now that's, absolutely not the case. And I just wondered if you kind of ran into that some in your studies.
I did run into both some conflict between the idea of traditional healers versus religious or faith healers. And then that's where I was like, this is already a really extensive research project. And if I keep broadening what I'm doing, this paper is going to get way too long to handle. So I basically ended up excluding anything that included faith healing, just because my understanding was that it was so separate from what traditional healing is now, although I know exactly what you're saying, that traditional healing's roots came a lot out of the faith aspect. But even when I asked I didn't get to talk to any traditional healers from India. I spoke to the ones in North America. So that was also a limitation, but even the psychiatrists that I interviewed, when I brought up traditional healers or brought up faith healers, they were like, two different things. We're going to talk on traditional knowledge systems. Faith healing is something so different. We don't even feel like we can comment on it. And that was kind of how I felt at the end of the research too.
Right. And of course, in the United States, if you say faith healing, that means something much, much different.
Yes.
Yeah. Okay. Thank you.
Thank you.
You have a question from Bali Chan, Wofford alumna, and she's at work, so I can read the question. And how do you think you or mental health campaigns could encourage patients with mental illness in India to seek treatment with the stigma of mental health that is still present in many parts of India? And I would just add to her question, the stigma that exists in many parts of the world. So yeah. It's a sweeping question.
Yes. This is a great question, Bali. Thank you. This is actually a more in-depth part that I did get to go into, because a lot of the current research studies are having to overcome stigma themselves as they're trying to task share and incorporate mental health into primary care. So what I found is that what we're used to in America, at least, or in the Wofford context even, of anti-stigma campaigns, it's like, here, let me hand you educational materials, like let me post this Instagram graphic. Maybe I'll even talk to you about stigma to try to destigmatize mental illness. The studies that I found tried similar approaches, like going and knocking on door to door, or just like having pamphlets out. And the result of those things was that they did not really destigmatize mental illness or increase access to care. Successful approaches, though, have done more participatory methods. So having people who live in whatever community the study is in, who might be actors, they might film something about mental illness, about seeking care. So they're having people within that context as actors in a film, and then they do what's called narrow casting, where they show it not like community-wide, but to groups of 3 or 4 people, 5 or 6 people, watch this film and have discussions about it. So breaking down stigma in groups of people, letting people talk about it. And that seems to be working. And that is the most successful approach really that I've seen so far. In addition to just task sharing itself, like having community members as the ones talking to people about it is so much better than having doctors or people not used to the context, because they understand the stigma around mental health and know exactly how to interact with people in that community, which is another big part of that.
Very good, very good. We have a question from Elisa Rogers. What advice do you have for future presidential international scholars, aside from avoid pandemics?
Yeah, I was going to say, don't be the presidential scholar in the year of a pandemic. Flexibility. I have talked about this so many times. Adaptability. I feel like I've kind of been a broken record with those, but I would not describe myself as a flexible or adaptable person, but this experience challenged me to do that. Even not in a pandemic, presidential scholars are traveling around the world by themselves sometimes. So flexibility and adaptability, I think, are key, not just in like your actual studies and reframing your research question if you need to, or finding different methods, but also like in your personal life as you're traveling by yourself or like figuring out where you're going, being flexible. I've definitely become more flexible. I still wouldn't describe myself as a flexible person, but this year has made me more flexible. And I think that's what you have to go into the Presidential International Scholarship with, because it's not going to turn out the way that you think it does. It will, even not in a pandemic.
I second your flexibility and adaptability. I know it was a challenging year, and you continued to think of ways to realize your research goals in creative ways, and there's always lemonade to be made from lemons, and you made lemonade out of a very challenging situation, Margaret. So any other questions? I'm seeing if well, Margaret, I think we've completed all our questions. So let me take the opportunity to thank everyone who joined us today. Thank Martin and Dudley, who have helped with the technology. Dean Lancaster, who helped and assisted you along the way, Professor Lefebvre. And I just want to once again commend you for your perseverance. And you've ended up creating a really thoughtful, meaningful project that has real significance, and I hope will help shape your continued studies in graduate school. So congratulations, Margaret.
Thank you so much, President Samhat. And thank you to all the people he mentioned, and thanks to all of you for coming to watch today. I really appreciate it.
And we will see you tomorrow and
Yes.
Saturday and Sunday, everybody.
Yes,
So,
sir.
great. Well, thank you, everyone. And that concludes this year's presentation. We look forward to next year. Bye-bye.